treating, there are two options. One is an angioplasty, second is bypass surgery. I'll tell you about angioplasty. It's what we deal with. Angioplasty is a technique of passing a catheter through either the leg or the hand, and we reach the heart, and once we detect the blockage, we cross the blockage, we use a balloon to open up the blockage.
Dr. Saab, I've been hearing a lot about this procedure called angioplasty, and I'm told it's non-invasive and the patient can be aware of what is happening. They don't put him in a what do you call it, as a anesthesia situation. So could we explain a little bit, and what when does this patient need, when does a patient need angioplasty?
Right. Angioplasty is a technique of opening blockages in the arteries of the heart. Like I said, when you have a heart attack, you have the blockage in the artery supplying the heart muscle. Now, you can either have you may not have a heart attack, but you can have angina also. That means when you exert yourself, when you walk, when you climb, you get chest pain. You investigate yourself, you find that of course there are some arteries which are narrowed down and you need something to be done for it. When you have a blockage in an artery, you need to improve the blood circulation back into the heart muscle, because the heart muscle is extremely important. If the heart is there, then the rest of you is there, right? We ignore the heart because we don't see it. It doesn't bother us on a daily basis. We don't even realize our heart is pumping right now 70 beats a minute.
Very true.
Right? So, and it is doing it silently. What we see bothers us. What we don't see, what we don't know doesn't bother us. So the heart is one organ which works silently, and typically when you have angina or a heart attack, there's a blockage which is compromising the blood supply to the muscle. You need to do something about it. What do? You do an angiography. After all the tests are there, you do, if necessary, do an angiography. It tells you where are the blockages, what are the type of, and how long is the blockage, multiple branches, involving branches, not involving branches, involving the main artery, there's calcium, no calcium. A lot of factors come into play when we look at an angiography. Now, once we do an angiography, it tells us whether these blockages need to be treated or not. Now, treating, there are two options. One is an angioplasty, second is a bypass surgery. I'll tell you about angioplasty. It's what we deal with. Angioplasty is a technique of passing a catheter through either the leg or the hand, and we reach the heart, and once we detect the blockage, we cross the blockage, we use a balloon to open up the blockage. All right. These balloons are made of the polyethylene or PVC, and these balloons are there to just open the blockage and re-establish the flow down the artery.
So it's
now,
like it's fixed there. The balloon
no,
is fixed.
the balloon is not fixed.
Okay.
The balloon comes out back over the wire. Okay, well, the wire is through which we thread everything. Now, what used to happen in the early 90s, I mean late 80s and early 90s, when angioplasty became popular in India, was we used to use only balloons. There were no stents. But we also realized that when we use a plain balloon, open up the artery and leave it alone, 50% of the patients will come back in 3 months with a reblockage. And almost 10% of patients, the artery would close off in the first 24 to 48 hours, and the patient will come back with a heart attack.
No.
So that used to happen, and that's why to prevent that, the stents came in. And the stents had a problem. There was there's a recurrence inside the stent, because when you put a stent in, you're causing some injury, and there's a healing process. When the healing process happens, if the healing process is excessive, the stent can re-narrow again. So and the angioplasty got a bad name, saying that you do an angioplasty, you're going to come back with a blockage. So that's where you got the drug-eluting stents, so the new stents which give drugs inside the thing. What drugs were those? They were drugs to prevent this ingrowth of tissue or reduce the ingrowth of tissue inside the stent. The recurrences came down. So today, when we do an angioplasty, 99% of the patients, we use a stent also to open up to keep the artery open. What is the downside of an angioplasty? About 6 to 7% of patients you do an angioplasty on will come back with a repeat blockage, as a matter of fact, over the next 1 year or 2 years. That's because of the natural history of the ear. They could have deposition of cholesterol inside the stent. About 1 in 500, 1 in 600 patients can have a closure of the stent suddenly.
Okay.
Because it's a metal and a clot can form inside. But with all the techniques that we have today, we have minimized all these things. But a patient needs to understand this before going in for an angioplasty.
Yeah.
You ask me who is suitable for an angioplasty. Suitable for an angioplasty depends upon various reasons and various things like the size of the artery, the area where the blockage is, what are the arteries involved, how many arteries involved, length of the blockages. So, and a lot of factors come into play when we decide about angioplasty. So we still have, when there are multiple blockages, multiple arteries involved, we still have the option of bypass surgery in these patients. So all patients don't need to go for angioplasty. Some patients we may ask them to go for a bypass surgery also. So angioplasty is a technique where we use a balloon and thereafter a stent, and there are certain other things also that we use, drills, etc., to clean calciums and to re-establish the patency of the artery and get the blood supply back to normal.
So another question, on an average, what should be the lifespan of the stent once it's fixed?
Yeah, good question, because every patient asks me this. There's no lifespan of a stent.
Okay.
A stent, once it is put into your artery, it gets covered by normal tissue of the artery, okay, in 3 months' time. In 6 months, if you put a scope inside also, you will not see the stent. The stent is already covered by tissue,
okay,
right? And there's normal tissue over it. Now, this normal tissue, you have seen some people with, you undergo surgery, you have a small, you can't even see the scar, right? You got to hunt for the scar. Some people, you see that the scar is large, huge, right? So the same way, when you put a stent inside, you are putting a stent at 15, 16 atmospheres, all right? And that's almost 300 pounds per square inch pressures on the artery. When you do that, you're causing some injury in the tissue, and that injury has to heal by scar formation. If the scar formation is less, you won't have a recurrence. If there is deposition of cholesterol inside the stented area, you will have a recurrence. If you are diabetic, you don't take care, you just lead a normal normal life without any restrictions, you're going to have cholesterol deposition back inside there. That happens, the stent will re-narrow. So stent doesn't have a life, but 7% of patients who we do an angioplasty on will come back in the next 1 year or so with a repeat blockage, which may require a repeat angioplasty, okay, or may not require anything, or may require some medications, or in worst case scenario may require a bypass.
Okay.